Will you please welcome our keynote speaker, Father Tad Boholchik.
Well, tremendous pleasure to be here this morning. My thanks to the CFCS for making this possible. Delighted that we can have a segment here that deals with the question of dying well. I think this is such an important matter. I think a lot of families struggle with this, and I hope that you will find this to be informative and helpful, maybe even, as you ponder situations within your own family that you may have dealt with in the past, or even something that may be ongoing. So I do work for the National Catholic Bioethics Center. We're based in Philadelphia. We work very closely with the bishops, and this being one of the things that I do, travel and speak quite a bit on end-of-life issues, early life issues, and a lot of the ethical issues in between. So for our topic today, I thought I'd start out with BC here. He's checking out the definition of birth in the dictionary, and he sees that it is the leading cause of death. So, there's a lot that happens, between the beginning and the end, but we're really going to be focused largely on the end and on situations simply that constitute a threat to one's health, and how do you make decisions in those circumstances. So I think we'd all agree that medical technology has extended life. It has brought many blessings, but also some complications. And I think this is what we're going to be, grappling with here today. So we're going to be asking, what are we required to do as people are dying? And it's important that we get this right. Dying well is laden with many graces, and to die not well, to die badly, brings sadness. All right, he says, Miss Dugan, will you send someone in here who can distinguish right from wrong? We all want to know where the moral lines fall. Very important to get this right. But I think there's also, another sort of temptation that's out there, which is to say, well, when it comes to all of this technology today, when it comes to decision-making at the end of life, it's so bloody complicated that really it's just gray. It's all gray. You've heard that kind of statement before. And so people will say, well, just choose something. And in virtue of you choosing it, that's going to make it justified and right. Now, of course, that's a kind of oversimplification, and I think actually a failure to carry out what I refer to as due diligence here. In other words, it may look gray on first glance, but if we throw ourselves into it, we have discussions with the medical team, we're talking to the nurses, we consult with others, perhaps with your clergy, other trusted individuals. And I should mention in this vein, the National Catholic Bioethics Center where I work, we offer a free consultation service, and we do more than 2,000 consultations per year. So if you've got something that's particularly difficult and you're not sure, what should a Catholic do, feel free by all means to connect with us. Through our website, there's a page you can, has all the information for submitting a consultation question. You can call us, you can fax us if anybody still uses faxes, and of course email us, and we will get back to you. So my point is that when you do this due diligence, you have all of this consultation, you try to discern where the lines are here. What ends up happening is the gray indeed shrinks to a line. It's no longer gray, and you have an understanding that, yes, here's a line, and I need to be on the right side of this line. I need to choose what is morally appropriate here. Now, I think most of us have two big fears when it comes to death and dying and the prospect of technology. The first fear is something like this. Well, if I check myself into a healthcare facility, maybe a nursing home, they're going to start hooking me up to tubes and wires and ventilators and machines and all these other devices, and you know what? They're just never going to let me die. Too much technology. So I think, we all have a little bit of fear of that. And you go into an ICU, you see something like this, and you'd say, wow, there's a lot going on here, perhaps too much. The second fear that I think most of us have is actually the opposite fear. That, if I check myself into a long-term healthcare facility or a nursing home, they just might shortchange me. He says, I'm going to take a nap. Watch my plugs, will you? We don't want to be unplugged too quickly, right? Have a little segment here from Seinfeld, and you can see Kramer reacting in this very same vein.
Hi. How's he doing?
He's been sleeping a lot. He's still groggy.
Well, I thought a movie might cheer him up. I got him a Gene pick.
What happened to Vincent?
I'm kind of off of him. Outlet. Ah.
So we all want to get a fair shake out of the technology, right? We don't want to be unplugged too quickly. There's a process to the dying that's so important that we respect. So as we discuss this and navigate these waters, I want to introduce to you the ERDs, the Ethical and Religious Directives for Catholic Healthcare Services. This is a document, I actually always carry a copy of it in my coat pocket. It's something I refer to with, great regularity. It was put together by the Conference of Catholic Bishops, and it's a great little summary, if you will, of the basics of Catholic bioethics and medical ethics. So if you have any connection to healthcare yourself, you should get a free downloadable copy of this at usccb.org and become familiar with it. It's a fairly quick read. So we'll reference it as we discuss our topic this morning. And what I want to focus on is this distinction between proportionate interventions and disproportionate ones. Proportionate treatments or disproportionate treatments. So the bishops give us a nice initial definition in number 56 of the ERDs, and they say a person has a moral obligation to use ordinary or proportionate means of preserving his or her life. So we have a duty here. And then they give us a definition. Proportionate means are those that in the judgment of the patient offer a reasonable hope of benefit and do not entail an excessive burden or impose excessive expense on the family or the community. All right, so notice a couple things here. Who's making the decisions about their health care? In the judgment of the patient. So the patient should be making their own health care decisions. Now, sometimes that's not possible, right? Somebody will be unconscious. Somebody will, have some other state that makes it impossible for them to decide, and then another person will be designated. And we'll talk about that shortly. And you want to use proportionate means that offer benefit without too much burden. And you notice that expense is mentioned as well. Expense would be an example of a particular burden. All right, so just to make sure we're clear on this, our moral duty would be that when we determine that a particular treatment is proportionate, it's required. We need to do this in order to be good stewards of the gift of life that we have received. And on the other hand, if a treatment is disproportionate, we say it's optional. You do not have to do it. Now let me just clarify what we mean by that. If we say you do not have to do this treatment, so, particular surgery is being offered to your dad who's dying, and you realize this is really over the top, this surgery. You're convinced that it is disproportionate, and you decline that surgery. No sin is committed when you choose to decline that surgery because you have made an honest assessment, careful, through appropriate consultation and so on, and realize that this is not a proportionate, but a disproportionate or heroic intervention and not morally required. Now you notice we have two terms that pop up for the same concept, extraordinary and disproportionate. If we say something's extraordinary, that's another term for the same thing. But this one, even though this is a little bit easier, if you're talking to a family, they're having a huddle, the grandfather's dying in the hospital, the family members do not talk to each other about disproportionate interventions, right? It's too complicated, too bulky language. It's not real people language. Well, they tend to say, well, that might be an extraordinary treatment. But this disproportionate language is actually more precise. So specialists, people like myself who sort of live, eat, and breathe this stuff all the time, we actually prefer this bigger and more bulky term. And I want to just explain to you why, because there are certain misunderstandings that can arise when you choose to use the less precise term. So what sometimes happens, I mentioned our consultation service that's free. We sometimes will get someone who will say something to us like this. They'll say, well, I understand you folks have a list of extraordinary means. Could you please send it to me? Because I'd like to just drop it into my living will. And then we'll always have to say to them, oh no, I don't know where you got the idea that there's a list available, but we certainly do not have one. It's this idea that there's a top 10, and just give it to me and I'll be able to simplify all my end-of-life preparations. So people imagine, well, ventilators, respirators, open heart surgeries, organ transplants, these must be always extraordinary means, right? And in a sense, what they're trying to do is they're focusing on particular treatments or even sometimes particular machines, like a ventilator, and say, oh, ventilators are always extraordinary. But that is not the case. Sometimes a ventilator will be ordinary, other times it will be extraordinary. So this kind of list is a no-can-do. Doesn't work. On the other hand, if we don't talk about extraordinary, but we talk about disproportionate, or not ordinary, but proportionate, what is the next question we want to ask when we say, oh, proportionate, it's proportionate. Anyone? Proportionate. It's proportionate to what? Very good. To what? Because you see what this does? When you use the term proportionate, you're sort of asking about the whole context. So we're saying this patient in this bed, in this hospital, at this particular time, with this constellation of symptoms, now we can talk turkey. If you're just trying to focus on a ventilator and drawing a moral conclusion, that will never work. So that's why this terminology is generally preferable. All right, so just to go back to something we said earlier, I want to ask you a question. When you're in a situation, say your family, and let's say the doctors have offered a particular surgery for you guys to think about for your dad who's dying, what are the two key criteria that you are going to need to be thinking through about that surgery in order to know whether it's required or not, whether it's proportionate or disproportionate? What are the two key criteria. I'm actually looking for just 2 words here. Just 2 words. What are the 2 general words here that would categorize this?
The benefits outweigh the burdens.
Very nice. Benefit versus burden. Key concept here for all of us to wrap our minds around. This is what you're always going to be grappling with. How much benefit can I anticipate from that surgery? What kind of recovery? Is the recovery going to be really hard? If it's going to be hard, there's going to be a lot of burden, right? Is this going to be super expensive? That's another burden. We don't have good insurance. All those kinds of considerations. All right, so just so that that's front and center in your mind as we go forward, and then we're going to go into this in a little more depth. So if we want to know whether we're dealing with a proportionate intervention, here are some of the types of things we got to think about. Does it offer a reasonable hope of success? Is this something that is done routinely by doctors, or is this experimental and kind of a long shot, 1 in 1,000 chance that it's going to help? So in other words, docs will sometimes say this is standard of care. Means it's used all the time, routinely works. We're going to be wanting to ask, how inconvenient is it? What are the risks? What are the side effects? So again, that's on the burden side, right? What are some of the burdens? So when we say, what are the risks and side effects? Anytime you go and visit your physician and he prescribes you, let's say, some new drugs, you need to find out, what's the safety profile of these drugs? Oh, doc, I'm also taking some other drugs. You want to know what are the burdens, what are the risks associated with this. So we need to be doing that with whatever the proposed intervention is. So here, the doc appears with all the prescriptions and he says, the top prescription is for your arthritis, but it may cause a heart attack. The second prescription should prevent a heart attack, but it could damage your liver. The third should prevent liver trouble, but it may destroy your spleen. The fourth protects the spleen, but has been known to eat away the prostate. The fifth, etc. You get it. It's a little bit complicated sometimes, to work through all of this, but important that we grapple authentically and fully with it. So back to our list. What are the circumstances of persons, places, times, and cultures? Now, I know that one sounds kind of vague, right? You're saying to yourself, gee, how do I have to think about that kind of thing? But I'll just give you a simple example. Sometimes I encounter people who will say something like this to me. They'll say, well, Father, all this technology and stuff is so complicated. Dying 100 years ago was so much easier. You just got sick, you got sicker, and then you died. And they'll say, oh, how I wish it could be like it once was. And then I'll say to them, no, you really don't wish that, because 100 years ago, we didn't even have insulin. And think of how many lives have been blessed and saved by the reality of insulin and all the incredible technologies that surround us day to day. So you cannot carry out your moral thinking in a kind of wistfulness for how things once were decades or centuries ago. What is the state of the sick person, both physical and moral resources? Let me explain this one as well. What we mean here, let's imagine that you have 2 54-year-old guys, okay? And the first guy is a hard-hitting businessman, type A, go, 24/7, never seems to stop. And all of a sudden, he had a massive heart attack, and he now finds himself in the back of an ambulance and has to make some acute care decisions regarding his particular set of circumstances. Versus the other 54-year-old guy who has amyotrophic lateral sclerosis, Lou Gehrig's disease. All right, so it's a neurodegenerative condition. He's had it for, let's say, 18 years, long and difficult years. Those 2 guys that I just mentioned, both 54 years of age, they bring different moral resources and strength to continuing the struggle, to continuing the battle. So this is pointing out that there's going to be a first-person assessment. I have to anticipate how much I can commit here to the ongoing battle to stay alive. And it's going to be different among different people. Does it involve excessive expense? I'm not going to say a lot about this one. People who are ethicists sometimes like to talk about this quite a bit. I'll just make a kind of general point. This depends on the details. Do you live in a society where there are certain safety nets that will offer coverages for people when they need medical care? Do you have good health insurance yourself? Are you and your family wealthy? Obviously, that's going to give you more possibilities, et cetera, et cetera. Those kinds of details will play, but there will be situations where perhaps a type of intervention will be offered, maybe a surgery, something new, some expensive newly developed treatment, and you realize that in order to get this for your mom, you're going to have to mortgage the house. None of the kids are going to be able to go to school. You don't have adequate coverage, etc. And that's going to be one factor among others that will have to be weighed and assessed as part of determining whether it's proportionate. So he says, I have some good news if you're rich, and some bad news if you're poor. None of us ever want to hear our docs say that to us, but it's a reminder to us of how the outstanding medical care that we get in this country does not come cheap. Back to our list. What burdens may be placed on others, family and friends? Now, this is a category, as you might surmise, that you need to be careful with, because you don't want to slip into that mindset that says, I really think we should put grandma out of my misery kind of thing. We can't go there. But as you're assessing, everything here on the screen and thinking this through, and you're saying to yourself, look, if a particular treatment is done to this family member, the outcome is likely that we are going to need to have somebody become a full-time, 24/7 caregiver for them. That's a lateral burden that will be one of the burdens among others that you will consider as you're trying to determine, is this required, is this proportionate, or is it not? All right, so conclusion here. A complex blend of factors which may need to be considered in making a judgment. Notice that last word, judgment. That's what we're attempting to do here, is to make a careful judgment. In fact, our moral duty is to make a good, prudential judgment. Prudence, as you'll recall, is the highest of the cardinal virtues, and it is super important for us to seek to live out that virtue, to make careful, prudential decisions, weighing all the variables that are in front of us and proceeding forward in the light of prudence. And to the extent that we do that, we are fulfilling an important aspect of our moral duty. Let me just, give you an example here. So maybe you've got mom who is dying, and her son has been designated as the proxy to make decisions on her behalf because she's no longer able to. And so the docs are coming to him. They're saying, look, here's one of the things we could try. We've got this particular drug. We're not too sure, but we think it would be, and he goes back and forth with them. He says, okay, let's give that one a shot. Then a week later, they're back and they're saying, well, we're not sure. She has a problem here in her intestines. We think we can do a minor surgery. Should we? And he says, yes. And this continues over time, where the son is making one decision after another, one good prudential judgment after another. And at a certain point, then, his mom dies. Now, he can be very much at peace because he was making careful decisions on her behalf. And in fact, when he himself dies, many years later, hopefully, and he meets his mom on the other side, she'll be able to say to him, look, you did such a good job taking care of me as I was dying. Thank you for that. Again, a kind of insight into the power and beauty of dying well and the importance of dying well. All right, so we're talking here about making some assessments that kind of sounds a little challenging, a little tricky. You got to think things through. You got to be attentive. You got to be consulting with people. So the foregoing definitions do not avoid all difficulties. There's always difficulty in estimating such factors as excessive, reasonable hope, proportional benefit, and so forth. This is just part of the process, and we need to understand this. This Dr. Kelly, who's commenting on this, he said, but this difficulty seems inherent in all attempts to make human estimates, and it's doubtful that we can ever attain to a formulation that will entirely remove this problem. So that's true. We got to recognize that we will get to the point of shrinking that line from the gray quite thoroughly, but there's still, we never have 100% certainty, and we're not required to have it. But we just need enough to make a good judgment of prudence. All right, so sometimes when I talk to physicians, to doctors, sometimes I'll do grand rounds in a hospital. I'll have a room full of physicians, and there'll be one of them who'll say something like this: well, rather than the complexities of a prudential judgment, Father, isn't there just a flow chart, an algorithm, or a database on the internet that we could consult for an answer? They'd like it to be very linear and straightforward. And I say to them, well, regrettably, that just doesn't work that way. Making prudential judgments requires careful weighing of sometimes what are almost moving variables, because as a patient is dying, their circumstances are changing. So he says, I'll be fielding your questions and my assistant will be Googling the answers. So I've alluded to the importance of healthcare proxies, somebody who makes decisions for you. I also want to bring in living wills. These are important when we're dealing with end-of-life situations. And I have a video clip here of a Catholic physician who's commenting on some of the limitations and problems with living wills. You're going to hear me kind of cautioning you about living wills, and he sets it up very nicely here.
A number of patients over the years have given me a copy of their living wills, and I would at great length discuss the situation with them. If you think about living will, an individual is writing a blank check in a sense, maybe years before the crisis arises. They don't know in which hospital they will be, what kind of a medical problem they will have, what the options of therapy will be, or the drawbacks of same. So it's really a blind kind of a concept.
All right, so you notice he says it's sort of like writing a blank check, and it's sort of a blind concept, he refers to it. And this is true. I mean, think about how this happens. You're sitting at home in your big comfortable armchair, and you have your yellow pad in front of you on the table, and you're starting to write down, if this happens to me, then I want this. If this, then I want this. And it's like this may be years, maybe decades before any of this ever even arises, and the stuff you write down may have almost no correspondence to what actually happens to you when you get sick. So this is one of the limitations. It's a blind kind of a concept. You're trying to imagine. And what's the other danger here when you're sitting at home and trying to imagine things? Fear steps in. Oh, I'm afraid of this. Oh, I don't like machines. Oh, I don't like this. Oh, I don't like that. Making healthcare decisions driven by fear, making any moral decisions driven by fear, tends to lead to very poor decision making. I think this is at the heart of many, many decisions, for example, to have an abortion. And then there's regret. So it's important that we, separate out these elements. Now, when it comes to living wills, maybe just share with you a little story. Dr. John Haas used to be the president of our center, the National Catholic Bioethics Center. And this story, it's a true story that he sometimes tells. He received a manila envelope in the mail one day. It was pretty thick. It was from a priest. And he opened it up, took out the contents, and there was a cover letter. And the cover letter said, "Dear Dr. Haas, I'm sending you a copy of my living will, and I'd appreciate it if you'd take a look at it and just let me know if there's anything in it that is contrary to Catholic teaching." And so Dr. Haas, took it out, looked at it, and flipped through it, and he noticed that it was 26 pages long, single-spaced typewritten text. So this priest had spent a lot of time on this. So some other duties, called. Dr. Haas had to step away. He left it on the edge of his desk. A couple days later, this priest called the center and said, "Could I talk to Dr. Haas, please?" And he got on the phone, and he said, I sent you a copy of my living will, Dr. Haas, and I was wondering if you'd received it." Dr. Haas said, "Yes, I did." And he said, "Well, I was wondering if you had any comments for me about it." And he said, "Oh, yes, just one. It's too short." Meaning even 26 pages of single-spaced typewritten text may not be enough to actually identify what happens or what befalls you at some arbitrary point in the future. So this is really not a very realistic exercise on our parts. What is preferable? Yeah, here's just to remind us, I don't want a bunch of tubes attached to me. I don't want life support. We sometimes let our fears here. We talk in these global generalized terms, and we should avoid that overly broad language. Depending on circumstances, tubes may be an important bridge to healing, and sometimes may be morally obligatory for us to receive. So again, just the word of caution about letting our fears rule the roost. So a surrogate or a proxy is generally preferable to a living will. The healthcare proxy, sometimes we call them durable power of attorney for healthcare, is a person who cares deeply about the patient and is able to make decisions in accord with the known wishes of the patient and with the patient's best medical and spiritual interests. So why is this generally preferable? Because now, even though you can't speak on your own behalf, somebody else will be talking to your healthcare team. Somebody else will be doing consultations, checking, feet on the ground, real-time information, making decisions as circumstances are changing. This is much better adapted to the needs of our patient that we're talking about here. It's much more dynamic and actual. So this is a much preferable situation. So it's so important for all of you to designate who this person is going to be. Now, if you're married, it's usually pretty easy. It'll be your spouse. But then you are going to have to say, who am I going to designate as a backup? What if my spouse dies before I do? And then you're saying, okay, we got 3 kids. All right, we got 3 girls. Now, that first daughter of mine, she's pretty faithful. She goes to Mass every day. But if she gets within 100 feet of a hospital, she faints. She can't handle any of that. But that second daughter of ours, she knows all the medical stuff. And she has a job that's connected to medicine in some way. But she doesn't share our values. I don't know if I could trust her fully with my life, putting my life in her hands. The third daughter, on the other hand, good balance there. She knows enough. She's got some gumption. She's not going to pass out in the hospital, etc. I think the third one is the right one. So very important for us, to think this through and designate who it will be. And I often say to young people, even when I speak at colleges on this kind of thing, you should, even though you're young and you think you're bulletproof, you can always step in front of the bus. You may not realize when that bus is right there. So the effective healthcare surrogate or proxy should be familiar with the moral convictions and wishes of the principal, of the patient, should be of good moral character, obviously, and should be capable of making sound decisions under stressful circumstances. I'd say these are kind of the broad requirements for a good proxy. Now, a quick word of caution here regarding some other living wills, especially ones that contain check boxes to indicate choices. Sometimes, for example, you may have heard of 5 wishes or post forms, or sometimes they're called post or most. These forms basically give you check boxes, and a lot of times there will be a facilitator at the hospital who will show up to the patient's room waving one of these, brings it in and says things like, well, you really don't want to have something like a feeding tube, would you? And then they sort of use all this negative. You wouldn't want to ever have to rely on a ventilator, right? You really wouldn't want this. And then they're checking no, no, no. All the check boxes, then it gets signed by a nurse practitioner or by a physician, and then it goes into your medical record and becomes a standing set of orders that are to be actively followed. This is one of the worst ways you could make healthcare decisions. You should instead allow your proxy to be the one who interacts and chooses on your behalf. But this kind of thing, a lot of the doctors like it because it's written down and then they can just say, oh, what's it say on the post form? I'm just going to do what it says there. They don't have to interact with the patient or with the family as much. It's kind of a shortcut, but not a good way to go. Another type of advanced directive just worth mentioning is the DNR, do not resuscitate order. And these you have to figure out, is it appropriate or not? So there will be circumstances when they make sense, and there'll be other circumstances when they don't. So if somebody is very elderly, maybe has already been resuscitated after a heart attack one time, and it shattered a couple of her ribs, and she hasn't fully recovered from this, and she's got ongoing cancer with the terminal diagnosis anticipated, not too far in the future, meaning a month or so, maybe. And the docs ask the family, what about a DNR? What if her heart stops? Should we do a full code on her again and maybe destroy, some more ribs, etc.? Well, that may be a very reasonable case where you say, we want a DNR, do not resuscitate. But there'll be other cases, where somebody's younger and they've got stronger rib cage, they've got a lot of other vitality to them, they don't have cancer, and it wouldn't make any sense to put in a DNR. You want to give them a fair chance. You want to try to resuscitate them, do the code blue, bring them back, and offer them that path into the future that seems much more probable in their case based on the medical particulars. You notice this is a bracelet. It just reminds me, years ago I was speaking in Reno, Nevada, giving a talk like this, and afterwards there was a woman who came up to me and she said, I just want to share my story with you, Father. I'm a nurse, and my dad was dying a few months ago, and in the hospital where we were, I was his proxy. And I said to all the nurses at the nursing station, I said, Dad's not ready for a DNR. She knew his medical condition quite well, and had been tracking with him virtually every day at the hospital. And she said, one day I arrived at the hospital, and to my surprise, there was a DNR bracelet on my dad's wrist. So I went to the nursing station and I said, what's going on here? Where did this come from? And the nurses kind of hemmed and hawed, and then one of them said, well, we asked your dad and he seemed like he wanted to have it. And she said, my dad's in no condition to be making these kinds of decisions. You can see that clearly. That's why I'm his proxy. So she went in there with a pair of scissors and cut off that band around his wrist. But unfortunately, when she came back a few days later, there was another one that had been put on to her dad. So there's, of course, it's a reminder to us that there's a need to pay attention, be vigilant, be present to your family members as they are in these difficult situations, and be willing to speak on their behalf and sometimes to step in kind of in their defense. All right, so I want to mention our Catholic Guide to End-of-Life Decisions. This is a 4-page summary, really, of the talk that I'm giving you today. It's available on our website, ncbcenter.org. I think it's $2 or $2.50 maybe for a downloadable PDF version. We've sold tens of thousands, I don't know, maybe 100,000 of these. They're just, people are really, really interested in this. So as it says, it's an explanation of church teaching on advance directives, euthanasia, and physician-assisted suicide. So just so you know that that's available out there. Sometimes parishes will buy 50 of them to distribute. All right, another segment from Seinfeld dealing with some of these end-of-life decision-making.
Jerry, you ever seen the movie The Other Side of Darkness?
No.
It's about this woman in a coma. Well, I couldn't finish watching it, so I want you to read this.
I, Cosmo Kramer, having just seen the movie The Other Side of Darkness, and not wanting to be in a coma like that lady in the movie, hereby want Jerry Seinfeld to remove my life support, feeding machine, lung blower, etc., etc., etc.
Can you do that for me, buddy?
Well, I don't know if what you have here constitutes a legally binding document.
Well, I'm gonna type it up.
Yes, well, of course, but even so, you may want to talk to a lawyer.
Well, Jackie Childs, he put a restraining order on me. I'm not allowed within 200 feet of his office. I couldn't even give him his Christmas present. Did you take this out of the garbage?
Yeah, it's still got some spring in the strings.
Jerry, this is a piece of junk. How are you gonna be the executor of my living will? You see, you can't let go.
Trust me, Kramer, given the legal opportunity, I will kill you.
So you notice here there was also mention of, maybe you should get this document to a lawyer, etc. And certainly you can do that, and I'm sure some of you have, in your end-of-life planning, taken a step like that and drawn your lawyer into the procedure. Now, note, you do not have to have a lawyer in order to prepare a valid living will. And in fact, what I usually recommend to people is that if you are going to have a living will, what you should do is, for example, download from your diocesan website the form that they offer, or from what I showed you from our center, in the middle of that document, we do include a sample living will. And then also remember that just because you downloaded it from somewhere, you don't have to follow it precisely. There are certain things, if you decide you want to cross them out, it is your living will. So you have the ability to specify what it is that you want. And sometimes the lawyers just give you this boilerplate thing, and people just sign it at the end, and they're not even sure what they've signed. So that's not good. You don't want to be doing it that way. All right, so just to sort of look at the chain or the hierarchy here, the patient, in ideal circumstances, will be their own decision maker. But if they're not able to, then it'll be the surrogate, the proxy that they've chosen. And if for some reason that individual weren't able to, physicians could consult the advance directive, meaning the living will. And the other thing here to understand is that the advance directive or living will also serves as kind of providing some guidance back to the surrogate or proxy as they are deciding particular treatment decisions. All right, so here's a true or false question for you. If a patient writes down a request in his or her living will, that request must be honored and carried out by their healthcare team. True or false? False. That is false. Let me just give you one example. I mean, there are a number that one might be able to cite here. Going back to our ethical and religious directives, number 24, it reminds us that a Catholic healthcare institution will not honor an advance directive that is contrary to Catholic teaching. If the advance directive conflicts with Catholic teaching, an explanation should be provided as to why the directive cannot be honored. So somebody writes in their living will, if I'm in a lot of pain, I really want you to make sure that physician-assisted suicide is available to me. That's not going to be able to be followed, that kind of request. All right, one more from Seinfeld, dealing with kind of designating some of these choices.
Situation number 4. You're breathing on your own, you're conscious, but with no muscular function.
Well, would I be able to communicate?
I don't see how.
I don't like the sound of this one.
Yeah, let's pull the cord.
Yank it like you're starting a mower.
Moving on. You have liver, kidneys, and gallbladder, but no central nervous system.
Well, I gotta have a central nervous system.
Okay. 1 lung, blind, and you're eating through a tube.
No, that's not my style.
Boring.
All right. You can eat, but machines do everything else.
I'd stick.
Yeah, stick. Because I could still go to the coffee shop.
That's right.
So you see the various goods that they're trying to weigh and assess, and I mean even a statement like, well, I got to have a central nervous system, right? Of course, hearkening to issues of when we die and brain death. All right, one more true or false for you. If there is a conflict between a living will and the wishes of the healthcare proxy, the living will always prevails. False. That is also false. The living will, as I said earlier, should be seen as advisory to the proxy, but clearly you want the proxy to be the one who's making these decisions. They're likely to be much better informed and engaged. All right, now I think there's a certain movement afoot, if you will, in the medical profession today to turn everything into a kind of declaration about autonomy. So if the patient says they want this, that has to be followed. Whatever the patient says they want, it's sort of as if it's the final word. And the reality should be more, as I've been hinting at, consultative. That it's not just the declaration by the patient that is going to make things right. You want to have the patient talking to the healthcare team and talking with others who will advise them and give them good guidance. So this reductio of ethics to autonomy, sort of autonomy becomes everything, I think is a temptation that's out there. And I have a video clip here. This is from an old bioethics training tape, and I'll just set it up for you. There is a nursing home administrator, and he's talking to a woman who's sitting in a wheelchair. He's getting ready to admit her to the facility, and he's just letting her know about the kinds of choices that she can make.
Whatever decisions you make should be your decisions. You decide in the event of a terminal illness whether you want certain treatments or not. There are no right or wrong choices. You tell us what you want, and we'll follow your wishes as long as they don't conflict with the policies and procedures of this nursing home.
He says, there are no right or wrong answers. You just tell us whatever you want, and in virtue of you declaring it, I'd say, okay, except, there's some little proceduralia here in terms of what the nursing home, might have. Of course, this is a vast oversimplification. There are right and wrong answers, and we need to be eagerly pursuing them, with the mind that the Lord gave us, through prayer, through reflection, etc. Sometimes you'll run into this sentiment. Oh, Dad wouldn't have wanted to live like this. I always say to people, of course he wouldn't. We all know that. Things happen in life that we don't want sometimes. But a phrase like this sometimes becomes a kind of excuse for neglecting Dad or failing to give Dad what is his fair share. We can't go there. We have to be very, very attentive to that. And I want to mention that sometimes when you see Dad in a situation where he's really, really compromised and he really can't do much for himself, maybe nothing. Maybe he's comatose or limited in some other way, and people are like, oh, this makes me uncomfortable, and I don't see what the purpose is. They'll say things like that. And I've even heard people go further, and they'll say things, look, Dad's lying there like a sack of potatoes in the bed, and all you're doing is you're sticking him with needles, and you're doing other things to him, and it just seems so wrong. Well, I mean, there is always the question of how much burden versus benefit. But when there are benefits, we have to weigh that very carefully. And there's another piece here. We need to think about, what is the Lord doing by leaving people with us who have limitations, who have disabilities, who have handicaps? The Lord has his reasons for doing this. Just to share with you what this reflexive dimension, by reflexive we mean it comes back and it changes us, you and me. When you care for somebody who cannot even acknowledge that you're caring for them, you maintain human solidarity with them. You affirm their dignity as persons. These are great values. These are important realities. You manifest benevolence towards them, benevolence and love. You maintain the bond of human communication with them, even if they cannot respond to or recognize the affection shown them. And I would say in a certain sense, this is the most authentic manifestation of love, when you are caring for somebody who can never say thank you back to you. That's their concrete circumstances. So I want to, with that, say a quick word about quality of life. This is a phrase we have to be, I think, attentive to. Quality of life. Because what happens is, and I'm afraid physicians, when I talk to physicians, I say the same thing to them. I say, you guys have to be careful, because I think you are not using this term in a coherent and reasonable way. Because when you say, oh gee, the quality of life of that person, it's really not very good, then what is that? Again, it becomes something like an opportunity, maybe an excuse to fail to care for the person in the way that the person deserves, or otherwise neglect their particular circumstances. And we can't do it that way. We can't approach it that way. And this is where PAS, physician-assisted suicide, makes its argument. People say, well, the quality of life of that person is really low, and they're having a lot of struggles and pain, maybe, and therefore we should offer them the chance to commit suicide. Eminently unreasonable. This quality of life argument, I want to share with you a short video here that I think captures the single best rebuttal of the argument for quality of life that I have ever seen. So this is a former Boeing engineer, I believe, in Washington State. He has Lou Gehrig's disease. He's dying. He's talking to Laura Ingraham on Fox News. And this was, a number of years ago when in Washington State they were trying to legalize physician-assisted suicide, and which they ultimately did, regrettably. And he was arguing, we shouldn't do this. This is a really, really bad move. And then at one point in the interview, as you'll see, Laura turns to him and says, well, what about your quality of life? Here you are, practically disabled. What about your quality of life? And listen to the brilliant answer that he offers.
And talk about power to the people. Joining us from his home in Kent, Washington, is a man suffering from Lou Gehrig's disease. This former Boeing computer programmer has been told that he has only months to live, but John Payton is using that time to accomplish a mighty task. John, thank you so much for being with us.
Thank you for the opportunity.
John, first of all, how are you doing? I know you have only a few short months to live. Are you in pain right now as you're doing this interview?
No, pain is not normally a component of Lou Gehrig disease. My breathing difficulties give you an indication of what I'm in for. We typically die from pulmonary insufficiency.
Well, John, I want to know how a man with only a few months to live decides to focus on one task, and you're focused on defeating Washington State's ballot initiative that would allow for so-called death with dignity, which is assisted suicide. Why that issue?
Well, I'm one of those people who is somewhat a target of the initiative, and I don't know how we as a society could really consider making doctors into killers. And that's what we're really doing with this. A physician writes a prescription for a lethal dose of medicine. He becomes an accomplice in suicide. He's really assisting in the killing of an innocent human being.
And John, I think a lot of people who are for this type of assisted suicide would say, look, well, what about the quality of life? I mean, look, people suffering like you, what kind of quality of life do you really have? What do you say to those people?
I have a marvelous quality of life. Right now I'm totally dependent. I can do nothing for myself. I'm effectively paralyzed. But I have a family, I have friends, I have my church community, I have loving support all around me. I don't understand how anyone could deny that I have a very high quality of life. And it gives me to understand and be compassionate toward those without the support that I have. But rather than giving them the temptation to kill themselves, we should be trying to figure out how to help them have the quality of life that I enjoy.
Well, John, your family must be so proud of you. I'm trying to hold back the tears right here, right now, but what an amazing life lesson of every moment on this earth. We all have something to give, and every life, no matter how compromised or medically compromised are the challenges, every single life is worth protecting and to be cherished. And I just want to say this is the best segment of this show, and this is the best segment of this whole week because you were on it, and thank you for doing what you're doing, and thank you for just being there. As long as you're here, thank you.
You're quite welcome, Laura, and thank you for helping me get the message out.
Absolutely. God bless you. John Page.
Bless you too.
Isn't that great? Yeah. Really amazing. You know, as he says, if you know somebody whose quality of life is low, what's the answer? Raise the quality of their life so it can be like mine. So important. He's talking about that support that we all need. All right, he says, before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance. You know, we kind of go for the quick and dirty sometimes, and we really shouldn't. All right, so to summarize here about technology at the end of life. First, it is okay to decline heroic or disproportionate interventions. Second, it's not okay to decline proportionate treatments. We need to do those to take care of ourselves. We must make reasonable efforts to feed the sick. I didn't kind of go into this in much detail, but the question of using feeding tubes will fall under the same heading. Is it likely to be beneficial, which it very, very often is, and how much burden is there associated with it? Actually, many types of feeding tube, the burdens are very low, and you can even have them put in under local anesthesia in a 15-minute type of an intervention by a skilled surgeon. So this will fall under the same heading. There may be some cases where, for example, people have intestinal problems that are so severe that any time you try to feed them, even through a feeding tube, the only thing that happens is repetitive projectile vomiting And obviously that's all burden, no benefit. So you're not required to feed under those circumstances if you can't stop the vomiting. It's not okay to declare a right to die as a euphemism for having a physician help me kill myself. And I think this last one is coming at us more and more. The pressure is mounting to encourage this and to, regrettably, draw medical professionals themselves, who are supposed to be the stewards of life, to turn them into agents of death. So to wrap up here, dying involves a lot of people. At the center is the patient. And in various orbits around the patient, you have the healthcare team, clergy, family, society. And one of the important things that I've been emphasizing is you want good crosstalk among all these participants. And if that's happening, if there's good exchange of information, there's good sharing, there's caring for each other, good decisions are likely to be made. This doc says, there's no easy way I can tell you this, so I'm sending you to someone who can. You know, a reminder of how also for doctors, good communication is very, very challenging. For all of us it is in these end-of-life situations. And to the extent that we can improve that, we're really helping people. So this is an important invitation to a journey. You know, I think when we see it as a journey, the journey into death, and we see dying as a process, that's sacred, a sacred process with meaning, we've already sort of set the right framework versus what our society tells us, which is, hey, stay away from suffering. Do whatever you can. Run away like a dog with your tail between your legs if suffering ever comes your direction. And I think here, what's the recommendation that they'll follow up with? Well, let's just short-circuit everything with physician-assisted suicide or euthanasia. And you short-circuit that, you lose all those powerful, beautiful graces that God was intending through the process that's marked out for you. Each of us is going to die in a different way from other people. No two people ever die exactly the same way. It's a unique journey, but such an important one that we indeed get it right and not allow our fears to direct us. So I have a video clip here that I think nicely captures some of the graces that I just mentioned, possibilities for growth through the dying process. This is a Catholic physician speaking on a panel about this.
Families have to understand dealing with a dying relative is a new experience for a lot of people. It doesn't happen every day. And you have to tell them that during this period of time, it's actually a privilege. And if they allow things to take place and God's grace to be given, that they're going to find that there is a stronger closeness in that family. There will be healing of some old wounds. There will be forgiveness a lot of times. And it seems that when this entire period of waiting is finally over and the person has died, they can sit back and look upon this as a time of enrichment and not a time that they were deprived or somebody was taken away from them, but there were positive things that did occur during this whole period.
So I think he's right on, and certainly I'm sure many of you could share stories of the death of a close family member, and you know, when you look back on it, you realize how many graces were unanticipated and marked that important journey. You know, he talks about, for example, forgiveness, and how there's something special about when people are dying. I am familiar with situations where maybe there were two people who had a blowout argument 40 years ago, And in those 40 years, they never said one single word to each other. Now one of them is dying. The other one shows up at the hospital, goes in, closes the hospital door, talks to the person, and there's healing. There's forgiveness. This is so important that we understand the beauty of the process that God is laying open to us. My grandmother used to say this, I don't want to be a burden to anyone. And that's an understandable sense, right? I mean, and yet I said to her, well, Granny, I mean, when I was a baby, I was a burden to Mom and Dad. When I was a teenager, oh my goodness, you can't imagine what a burden I was. And so I said to her, please be a burden. Let us care for you. Let us love you. And don't yourself feel burdened by this kind of thinking. So we need to reassure our elderly and infirm of our care and support for them. All right, I'm going to close now with 2 cartoons. For better or for worse, sometimes some kind of deep themes in this one. So she's on the phone. Yes, John, Mom is still with us. We're all taking shifts at the hospital. My brother is with her now. So we go to the hospital. Here's the brother. Strange, here I am watching my mother sleep. She looks so small with her hair spread over the pillow. And I'm wondering, how many times did you sit like this and watch over me? So a beautiful reminder to us of these cycles of life and death, of one giving rise to the other. We started with the cartoon from BC. We'll close with BC again. You have the 2 little ants looking up at the cross. Look, Jake, a note. So he's wondering what this is all about. Scampers on over, climbs up the cross, gets a good view, comes back down. What does it say? To be continued. And you see the open tomb. A beautiful reminder to us of how death is the stepping stone into our true home and to eternal life, and how important it is then, whatever we can do to facilitate and make it a graced passage for each of us. All right, quick mention here. If any of you are saying to yourself, gee, this whole thing about bioethics and medical ethics, I have an interest in learning a little bit more. I want to mention a program that I started about, must be 15 years ago, with Dr. John Haas, who I mentioned earlier. We have graduated from this certification program now, I believe, more than 1,500 students. It's an online course, web-based, with only, I think, 2 requirements that you show up in person, once in Philadelphia and once in one of the other regional cities that we offer a seminar in. And it's a great opportunity through weekly assignments to kind of go deeper and learn what does the Catholic Church teach on these very important life issues. So just so you're aware of that, and mention of our website again, ncbcenter.org. Also, I have a personal website, fathertad.com, with many bioethics resources available as well. All right, so thank you very much. Oh, thank you. Yeah, it looks to me like we have about 12 minutes or so for Q&A. So I see there's a roving mic. You notice what he says here. We'd now like to open the floor to shorter speeches disguised as questions.
I was just wanted people to be aware that the proxy person does not have to be a relative.
Correct.
Maybe it's somebody that is more to your a friend, a neighbor that knows what you want and will follow those rules and not be persuaded or guided by their feelings because they don't want to lose you.
Yeah, I mean, I think the problem of families, that sometimes families don't have the right dynamic, and somebody will realize, I can't ask a family member to be my proxy. And you're correct. You can choose a friend. You can choose anyone who you trust. And, my advice to you on this when you're choosing this person, you do want to spend some time here going through things. And it's a hard conversation sometimes to have. I remember, to give you a related example, when my own dad was dying, and I was saying to myself, things are not looking so good. I need to sit down with him. I need to have a conversation with him. And so I pushed, and it was a little bit awkward at first, talking about death, about his death that was coming. But then, he sort of grooved and got it, and before I knew it, he was telling me what color vestments he wanted me to wear at his funeral, and it all worked out very well. So I think there's merit to sort of being a bit courageous here and having these hard conversations. It brings real profit and benefit to all of us.
I've had several relatives who were 80, 90 years old, and they ended up having very serious surgery and open heart or such. But it seemed like they went through the surgery and they went through torture and then they died. And I'm just wondering, in both cases, that was their wishes, so we supported their wishes. But that one just seems like a real vague area on where the church stands on something like that.
Yeah, well, it really fits, I think, quite well with what we are looking at, in the sense that when you're looking at benefit and burden, you're mentioning an important burden, which is, the surgery may be able to fix some things, but what about a really, really hard post-op recovery? That's a huge burden. And if you're already weak and debilitated and elderly on top of it, you may be very reasonable to say, no, that surgery appears to have too much burden and not enough benefit. And you can make that decision. You need to make it as prudently as you can. And there will sometimes be variables that you won't know about, and sometimes there will be things that you couldn't anticipate. Like, I know people who have done rather complicated surgeries, open up the whole sternum, do something to the heart, close them up, and then what? Totally unexpectedly, they get a bad infection, and you can't plan for that, and then things go down. So you can only plan for what you can plan for, and their decision to do the heart surgery was reasonable, but then they got this infection, and then they died, etc. So we don't have total control over the variables, but we need to do our best with them, and then it'll still be, a good death. Yes, at the back there. I think they'll bring the mic to you.
Yeah, I forgot what I was going to say now. No, actually, my mom's going through very much what we're talking about today. So she's 88. She has very bad diabetes. She has heart condition. She has, her dementia is really bad. And she was, and I'll give you two situations this happened recently. One is she's in the hospital, and the doc says, well, we can do this heart surgery. I said, okay, what will it entail? And at the end I said, if it were you, what would you do? Just kind of get some feedback from him. And he said, given her age and condition and situation, he says, I wouldn't do it. I said, okay, then that's the decision. The second one was, she's in a nursing home, and I get a call from them. They said, well, do you want us to send her to the hospital, or do you want us to just treat her, basically allow her to go? I said, well, what is the situation? They explained it, and I said, send her to the hospital. And this was probably a good 6-8 months ago. And she's doing okay, but it wasn't a time to just let her lay there and die. She's able to communicate and eat and stuff like that. So she's in okay condition for everything that's going on. Mm-hmm. But those decisions that are either proportionate or proper, to ensure they have a good quality of life.
Yeah, good examples. And I like your you're sort of putting the question also to your doctor, because I do think many times doctors will be willing to do certain things, but that if you said, well, if it was your mom, you know, what would, and that's helpful. It's not always the right answer that the doctor gives you, but it's more information for you as your mom's proxy to be able to say, well, if the doc doesn't think this heart surgery is worthwhile and he thinks it's going to be way overburdensome, that's something I need to, you know, carefully think through. So I think that's excellent. The question of going to the hospital. Yes, yes. And your assessment that she was in a place where, you know, we're not ready to throw up our hands. She's perhaps still early in a decline or midway through a decline, but not sort of terminal, you know. And when she does get terminal, and it's clear that her time is very short, and if they call you and ask you, should we send her to the hospital, you may say, no, it's clear we're beyond that. And that'll be reasonable. So this is part of the sort of journeying with our loved one, that we recognize the condition is changing day by day. And sometimes it's faster than, you know, other times. Sometimes it's slower and much longer and seems almost chronic. And I think through it all, we have to ask the Lord for the right spirit of patience so that we can work lovingly with the person, you know, as he's getting ready to bring them home.
Let's see if I can formulate this question. With pain-killing drugs like a morphine, which can have the effect of shortening the life, but that's not the intended, it's the unintended consequence. But it was well, I'll just ask you, you need more and more of a dosage to keep the comfort level going. Is there a concern with that somewhere that, you know, where does it shorten the life and it's not moral? And when my mom died, it was almost like she needs more morphine. She looked like she was comfortable. So trying to tease out a question there.
Yes, excellent question. And it's really a question about the appropriate use of morphine. Because morphine, in a certain way, is a miracle drug and such a blessing to have for circumstances of severe pain. But what you're getting at in your question is, isn't there a very important moral duty to titrate the drug? And the answer is yes. And by titrate, we mean you give only enough painkiller that it's matched to the pain remediation needs of the patient. So you titrate. Now what happens is you titrate a particular dose, and that works, but after the next time you try to do it, she may need a little more, because maybe if, you know, let's say they have bone cancer, you know, which is very painful, it's getting worse. You have to give more. But you are titrating. You're not just saying, hey, let's snow this person and give them so much painkiller that they're going to be out of it completely and, you know, et cetera, and even push them over the edge, so to speak. That would not be morally appropriate. So, but titrating, and even if, you know, it gets to the point that, like with the bone cancer, you're titrating what's appropriate, but the pain is getting so bad, and you're saying to yourself, boy, I'm giving higher doses. They're proper doses. They're controlling the pain, but I'm afraid at a certain point it'll be such a high dose that the person will no longer be able to breathe. It'll cut into their breathing. That's a different case from the case of saying, you know, early on, oh, I just want to get this person kind of out of this life, and I'm going to give them a super high dose and send them over the edge. What that is, the other case where you're titrating properly, you may reach a point where you give a dose that you realize the dose itself may have cut into their breathing, but that would be morally allowable under the principle of double effect, because you are in fact giving a properly titrated dose and tolerating a second unintended, completely unintended effect, which is that it may also prevent breathing from occurring. So, you know, those are sort of subtleties, but I think today there is more of a concern, not about that sort of careful titration, but more what you're describing, that somebody doesn't look like they're in pain, and maybe the hospice nurse is saying, oh, double their pain meds. It's like, well, wait a minute. No, we have to give them what's appropriate and not much, much more than is indicated physiologically.
Just to add on to that, and I think this is where hospices or in hospital or in homes, there's always adjunct therapy when you're having a patient at that time period where they are in that process of deteriorating. And for many of them, it's anxiety. Morphine doesn't treat anxiety. If they're anxious in any way by how they're demonstrating their breathing or they're restless, many times you can use Ativan or another type of anxiolytic drug to give them comfort, because it's an anxious period for not only the family that's standing there or the healthcare providers that are there, but to try to make them comfortable, you may have to use other things. Morphine is absolutely the best in my experience, but there are times when the anxiolytic drug in combination will help with that and make you feel more like you're doing something to help for that. Because a lot of times, in some cases, they're having muscle spasms. Maybe they had a surgery because they fell and they injured their hip. The surgery, went through a muscle. And if for any reason that person isn't going to survive it, you have to be able to treat that. So it's got to be in combination, and typically most of the time that'll be the recommendation.
Yeah, very good. That's correct. I mean, Ativan is also widely used and, has an important adjunct role. I see a hand over here.
I'll share a quick story if you don't mind,
yes, please.
Father. My daughter gave birth at 23 weeks and 1 day. That is the exact age that the state of Michigan recognizes that a child is viable. So when she was in the emergency room delivering, they asked her, "Do you want us to save your child?" So she had to make that decision right then and there. She said yes. From there, the baby was delivered. She went into the NICU, and we were faced with a barrage of decisions from that point of what was, allowed, what we should do, what we shouldn't do. And I just want to thank you, because our priest at that time did reach out to your organization to find, do we keep her on a respirator? Do we, give her these drugs? How far do you go with a child of that gestational age before you say, we're not going to do anything more? But that, that's kind of the other end of the spectrum. We're talking about older people, but this does happen for families with younger children as well.
Yes, thank you for that. That's correct. And, worth mentioning that the basic criteria that you use don't really change, whether you're young, whether you're middle-aged, whether you're old. It's always benefit versus burden, that you're going to be weighing. Was there another hand?
I think we have time for one more.
One more. Okay, very good.
I heard the man say about his mother, 88, so it's deja vu. 2 months ago, I was in this situation with my mom. 4 siblings. We took 12-hour shifts for a month to hospitals and hospice. And the thing that I learned out of this experience, it was what my mother wanted, was to bring our family together.
Yeah, that's powerful.
We lose sight of the healing, the presence of being there, the example that we're setting for our own family members and friends. And I'll never forget my mom in her dying words. "I guess we raised you right." And
nice.
I think that's the words we need to remember.
Yes, thank you. Thank you very much. All right, well, that's a great note to close on. Again, the beautiful graces of a good death. So thank you all again.